I have my friend Caroline. We have known each other since we were teenagers back in Kentucky. We're from the same hometown. We used to go to pop-up shows and basements together. Back in the days, we spent a lot of time in Denny's. A lot of time, yeah, it was very limited place.
Yeah.
The teenagers pub with no alcohol.
Right. That's the place you're allowed to be if you're out of your house.
Yeah, and drink too much coffee.
Yeah.
But she is an emergency room nurse back in the States, which is, equivalent of A&E. And I have a list of questions that you all submitted that are really wonderful questions. But I thought first would be best we can explain kind of what the schooling is like for nursing in the States.
Yeah, it is. There's a couple of different tracks, but if you work in a hospital, the most common one is to get a bachelor's degree it's like a bachelor's of science in nursing. They call it a BSN. Some people do an associate's degree at community college level, and then they're an associate nurse, an ADN, I think is what they call it. But if you work in a hospital, especially one of the hospitals that has been awarded what they call magnet status, which is every inpatient hospital is always striving for magnet status, especially a teaching hospital. They want you they'll hire you as an ADN, but they want you to be getting your RN within, a certain period of time, because a bachelor's of science in nursing is what you have to have in order to take the RN licensing thing, or you have to, I guess you have to have one of the two, but to get, anywhere. So it's basically, a 4-year college degree is the most common thing. Yeah.
4-year degrees.
Yeah. And then for a nurse practitioner, it's changed recently, and it may be about to change again. But a nurse practitioner basically works as like they're supervised by a physician, but they can do a lot of the care. It's kind of a little bit of a hot button topic. I was just like, oh, I'm going to get myself in trouble saying, speaking in absolutes, because what I was going to say is that a nurse practitioner is pretty close to being a doctor, but now I'm like, oh my God, nurse practitioners, doctors are all yelling at me about that, because it's not very exact. But they can prescribe, they can do procedures that RNs can't do, and that's also true. There's another level that's kind of community college level that's LPN, and there's certain medications that they can't give. There's all of this sort of fine detail differences between the licenses that is not especially important, but that's one of the things that those different designations indicate. But an RN is a step below a nurse practitioner, or a PA, a physician's assistant, or an MA, a medical assistant. And those I don't have a good understanding of what differentiates them from nurse practitioners and what differentiates them from MDs, medical doctors. So,
how would you say a nurse practitioner goes to school for?
A nurse practitioner, this is the thing that changes. I think now they do want you to have a doctorate to be a nurse practitioner. It was just a graduate school type of thing. Everybody that I started nursing school with that has gone on to become a nurse practitioner, I think they were kind of under that wire of the change of having to have a doctorate to be a nurse practitioner. And it was pretty controversial, because it was one of those things where it kind of created a bigger barrier for nurses advancing into practice. And who wanted to put that barrier up, it's unclear. Why and why is also unclear. So people have lots of opinions about it, but I am not one.
Do you feel like in recent years America is struggling to get enough doctors? Isn't there, correct me if I'm wrong, or if I'm not sure, that they try to limit how many people can become a doctor each year, but we kind of need more doctors?
I don't know much about that particular issue. I know that it is, becoming a doctor is, to me, kind of sounds like cruel and unusual punishment. The residents have to do all of this, they have to work these terrible long hours. They don't get paid even as much as RNs do when they're a resident. They're working in the hospital as a resident. They don't even get paid as much per hour as RNs do.
I think that's a real common misconception people have here about the U.S. healthcare. They assume because it's private that the doctors are all just making bank. And I've tried to explain to people, of course, unless you're really specialized or in a specific hospital in a big city, are not rolling in it the way people
I think, a doctor who is, a family care doctor in a medium-sized town or city is they're very comfortably middle class. They own their home, they own their cars, they don't have, other than their medical school debt, they, mostly don't have debt that affects their lifestyle. They can afford to pay all of their bills and they can afford to have nice things and a stable life, but it's not a yacht situation, right? Like those are doctors who have other family wealth, or they are super specialized, especially apparently dermatologists are always perceived as being really wealthy. And it's one of those things that sometimes people are like, well, people who work in dermatology practices, they have easy work and they get paid a lot. Right. So
it's elective, not really dealing with a lot of interest.
So elective is a tricky word in the American insurance. Like it doesn't mean you can choose to have it or not. It means life-threatening or not, right? Like somebody's hip replacement, right? Like so at the beginning of COVID, when they canceled all elective procedures, that meant things like hip replacements, orthopedic surgeries, things that people definitely need. But because we use this word elective,
right, good tell.
Yeah, it's basically, it's elective if you're gonna survive without it, even if you're disabled.
Oh, wow.
Yeah.
And I know insurance in the States, dermatology is one of those. They're pretty fickle on covering it. It's like skin, teeth, and eyes are add-ons.
Yes. Yes.
What would you say a ballpark price range is for going to nursing school in the States?
It varies as much as going to college for anything else, because you can go to a fancy private school or you can go to a state school. I went to a state school for nursing school and paid in-state tuition. And I think the in-state tuition it's not that bad. It's only about maybe $15,000 or $20,000 a semester, something like that. Maybe it's a year. I don't remember. I actually got a scholarship to nursing school, so I don't remember those numbers the way that some people do.
Yeah.
But it was, standard state university tuition, like comparable to, the University of Kentucky or something like that.
Okay.
Yeah.
Well, so I did want to go over the questions that people have submitted. There are some really good ones. And it's okay if some of these, if you don't know the answers to, or if you know part of the question or some of the other, because they do kind of ask some comparisons for here, and should it work in the medical field here? So we're going to try to figure out the details.
Well, it's like what I said to you the other day of like, I wish that there were a medical, and there might be for doctors, but I doubt there is for nurses, a work exchange cultural experience, right? Like I would love to go for 4 hours with a nurse in an A&E department or whatever you call it in a hospital here and just follow them around for 4 hours.
Yeah.
Just to see how things are different, because I have a vague sense of some of the differences, but I would be really interested to see what the practicalities of that are.
Yeah, it would be really interesting, especially for something like the emergency care, because it's the one place in the States you can't be really denied if you come in. Anything else is,
right.
When Josh had to go to A&E shortly after he moved here, when he was having a heart attack, it was a Saturday night at 1 a.m. There were people laughing, making small talk. Like the tone of the room was completely different.
Yeah.
I feel like it's because no one's like, how much is this going to be? How much is this going to be at the end of it?
Right.
Okay, so let's get into the first question. This one is from Neil Biggs. How does she think the regulatory practices compare in the two countries? Do you have any thoughts on which each could do better?
Well, that's certainly one of those comparison questions where I don't really know enough about how it is here. I know that a lot of the bureaucratic things that are challenging about working in the medical field in the United States are driven by the insurance companies. And so it may just be, when it comes to the amount of paperwork or whatever, administrative workload, it may be similar. But I know that I had to, one of my medications, I have to get filled on schedule, and therefore, and it's often out of stock because they don't make enough for what is prescribed. And so sometimes they have the brand name and sometimes they have the generic. And depending on which one my doctor sends to the pharmacy, that's what the pharmacy sends for approval to the insurance company. And if they're out of, say, the generic, then the pharmacist doesn't have the privilege, like the practice privilege to just change it. They have to send it back to my doctor and back to the insurance company.
Oh, gee.
And it's like, then because I work night shift, it's hard for me to make phone calls during the day. It's a weird phone call period, but I have that extra barrier. And so sometimes it'll take me like 4 days, and then there's just a weekend in there, then it just will take forever. And so you end up take a day off from your medication or take half a dose so that you have some backup in case you can't get your prescription filled on schedule. And it's like, this is really stupid. Yeah. And I have that happen I would say 1 out of 3 months.
Really?
I have to go through something like that for one of my prescriptions.
For something that you're taking
I've been taking every day at the same dosage and the same everything for years.
Which is bureaucratic.
Yeah. And I think that a lot of people talk about that kind of thing in the context of, from the American perspective, people like to say that, things about, if you have socialized healthcare, then it'll take you X amount of weeks or months to get your follow-up or your scan or your whatever. And I'm like that doesn't happen in the U.S. It happens all the time. In the ER setting, sometimes we get patients who bounce back to us because they have a persistent problem that they need to see a specialist for, but they keep, in the meantime, they have to wait, so they keep coming back. Right. So it's a problem regardless of the economic structure of it.
And that, I think that is another thing that's a common misconception over here, that people think that because you're private, the states, that you would be able to get specialists seen, all this, because there are delays, depending on that here to kind of triage how important it is. And then sometimes you have to go in the ER the same in between, but you're not compounding that bill every time while you're waiting for that next bill from the specialist when you finally get to that. But paying exorbitant amounts does not get you a specialist any faster.
No.
It's just an extra stressor, really.
Yeah.
Okay, so the next one.
I wanted to jump back to we talking about do we have enough doctors and that kind of thing? Because this came up on the live stream when we were talking about how it's that drain of talent and education from smaller communities and more isolated communities. You don't have a shortage situation in bigger cities where there are hospitals that are capable of doing higher level care, but it's not it's because there's a lack of doctors out there trying to get jobs at those hospitals. They're closing down the facilities. And you also don't hear people talking about a nursing shortage, but what there really is a shortage of experienced nurses, because it took me a long time to get my first job out of nursing school.
Oh, really?
Yeah, because a lot of jobs want you to have at least a year of experience, and those are the nurses that are lacking for a lot of places. I understand that.
That's interesting to hear, because I feel like that's so many jobs when you get out of college. It's they want you to have a degree, but then they already want you to have experience.
Yeah.
But they won't ever give you the experience. You just kind of up in a loop till somebody takes the chance on you. Yeah, it's wild to think about nursing struggling like that. It's as here, we need nurses, so why is this wall here?
Yeah.
So the next one we have is from Neil Morrison. Oh, I think I should kind of answer that. What is the career path for nurses in the U.S. like? In the UK, they can go down to a more administrative role, or specialize and become nurse practitioners, like my wonderful poor business nurse.
Yeah, there are a lot of, even before you get to the nurse practitioner level, there are a lot of really highly specialized nurses. Like the first one I thought of is I know several people who have gone on from being, bedside hospital nurses to being a wound care nurse.
Oh, wow.
Because that's a very special skill set that takes a lot of just experience to get to. I think they're called clinical nurse specialists. Like sometimes you'll see people have their little word salad after their name that represents all their certifications, and you'll see that a lot. CNS. Anybody, and you can also at a slightly there's various levels of specialty certification that you can get. It usually gets you a small in the next year I probably will get my what they call the CEN, which is a certified emergency nurse, and then I'll get a little bonus because of that as far as
this one is from Richard. I assume all the money asked for goes to the bosses rather than the medical staff. Would you say? I think a lot of people hear why they have those misconceptions that, well, the medical field in America makes so much money, and because they see what our hospital bills are and assume that must be divvied out, but it's really kind of going more.
A lot of it goes to the insurance companies, like those, especially the executives are among the higher paid people in healthcare, and it's like that. I think is why if we did it differently, it would free up some resources, because so much of that is going to all of these different insurance companies. And then there are people who work at the hospital and their entire job is to figure out what somebody's coverage is for that particular visit. And it's different, not just between which insurance company you have your plan with, but which plan within that insurance company, and your demographics sometimes play into it, and how much you've spent on healthcare so far this year.
The deductible.
Yeah. I actually and you will also think that if you work in healthcare, that the employer-based insurance that you have access to would be top tier.
Yeah.
And I will say, my current job, it's really good. It's the best one that I've had by far. But the one that I had before that, there's this sort of progressive deductible situation, which is, it looks good on the face of it, but then when you think about it, it's really a sneaky thing, because you have your deductible rate, which is you spend, say $7,000 out of pocket for a year, right? Like that's your deductible.
Or the offset here, because that's the same rate.
Yeah. And so I have planned for a while that my total deductible was something like $7,000. But it did this thing where if I had gotten to $5,000, well, then they'll pay 65% until you get to the $7,000. And then once you hit $7,000, then they pay a bigger percentage. It doesn't mean that, and it's something being covered, there's still maybe a copay when something's covered, right? Like I actually have met my deductible for the year, but I still pay my therapist appointments were $90 per session, and all of a sudden they're $21 per session, which is great, but I'm still paying $21 per session out of pocket, even though the cost of the insurance plan comes out of my paycheck. It just comes out of my paycheck before they tax it, which is supposed to be a compelling benefit.
Yeah.
But what happens is, when you get to that, you think if I get $5,000, at least then my out of pocket costs will decrease. But what it does is it makes it nearly impossible to hit that total deductible, right? Because as soon as you get close, they slow your spending down.
Oh.
So it looks good on its face, and I guess it could be worse, but also it means that you're not going to get to this point unless you just have catastrophic medical. So, and because so much of it gets absorbed by the insurance company, the insurance, bill that you actually get from the hospital does look insane. And I don't know, I don't know enough about the reality of what happens behind the scenes to say this definitely happens, but you would see where there would be an incentive for hospitals or any provider to inflate cost so that insurance then covers more.
Because the insurance will likely deny part of it.
Yeah, or they'll say, because you have this insurance plan, this is your cost for this procedure. That's the problem, right? It's because different insurance plans pay different total amounts for
the same procedure.
whatever it is. Yeah. And so that looks like your insurance is giving you a big discount on something, but it has also inflated the cost beyond what it actually, the numbers you see on the bill to me don't seem to have much to do with the reality of what it costs to do the procedure. It's just like, I'm sure it's not random.
The inverse lottery.
Right. Well, and it's like, and then you look at you get like an itemized bill sometimes, and it's like they charge you like per Band-Aid or something. This is like, whereas if it were just like, oh, the government arranges for the hospitals to be supplied, then you don't have to worry about paying per Band-Aid.
When you see like $9 for an ibuprofen given while you're there on your bill, like all those, what did it cost? What, like 10 cents for the actual pill?
Right.
And here, like the cost of an X-ray is like the same amount. The cost of a smear test, like all these have like any menu would have. Here's the price. Not like how much are you willing to pay for this?
Right.
Which not great. Makes it unpredictable.
It's unpredictable, and it also means that, like, in the moment, there's not a good way to answer somebody's question. Like, they can't make a fully informed decision about what they're going to do because the prices are so obscure.
Right. Well, actually, this leads perfectly to the next one. Julian Hall asked, probably a predictable question for Caroline, but how much do nurses in the U.S. bother about patients' ability to pay for their treatment, or is their attitude, who cares? It's my job to address their clinical needs, not their payment ability.
Yeah, I don't. And we take care of people all the time that are obviously in no position to pay, and it's certainly not any concern of mine. I think that's probably especially true in emergency, right? Because like most of the time, the stuff that we're doing, it's like we have to do it.
You just say like you can't.
Or in order to treat the thing that you came in for, this is the treatment. You either consent to it or you don't.
Yeah. Especially by the time you're in emergency, there's not a lot of You gotta make fast choices.
Right.
So Dallas asked, we've had more than one wave of British trained medical people immigrate to the U.S. for vastly higher salaries. Do you know how things turned out for any of our immigrants there, or was succumbing to the lure of higher income a mistake for them in the long run?
When I looked over the questions beforehand, I saw that, and if that was like the first I had heard of such a phenomenon. And that may have something to do with like the locations where I've worked are not particularly attractive to international providers, I would think. In particular, my first job was in an area where, like, comparatively, especially nurse salaries were low. There's an Irish nurse that works at our hospital in the emergency department, and I see her from time to time, but that's the only person, even from the region that I can think of. Yeah. And I think that she is part of like an there are like international travel nurses, and I think that that's what she's done. She's not so much like fully immigrated and stay forever. She's just working some clinics.
Yeah, I think a lot of people assume across the board in any field that Americans make more because they see our numbers. But when you actually do the exchange rate for USD to pound, and then you take out what you're paying for your insurance, your health care, like
last job, the total insurance premium, and my employer paid part of it, and part of it was a pre-tax paycheck deduction. But the total monthly premium was like $526.
And it's not based like, whereas your NI fee for what your tax goes into your NHS here is based on your income level. Whereas in the States, like, yeah, your insurance is just like, they don't care how much you make per check. This is how much insurance costs. This is
right. Well, so that's generally true. When I was out of work because of long COVID, I had state Medicaid, and that, because of my income at the time, which was zero, it was free. But it's kind of unusual to live in a state where the Medicaid system is worth very much. And I'll say also, like, in order to get set up with Medicaid, like even as an educated healthcare professional with very high like reading literacy, proficiency, it was like the paperwork that you have to fill out and like the supporting documents that you have to provide and all of that kind of stuff. It's very taxing. It's very taxing. And the paperwork, like when I was filling it out, I was thinking about like, for somebody who struggles with reading or who is less educated or like doesn't have the healthcare vocabulary, like this would be so like, it's unpleasant and difficult for me, but I can do it. And I'm sure that there are a lot of people who just don't bother because of the paperwork load.
I feel like a lot of the few programs that the states have, they make sure that it is to get over the bar is impossible, and then the amount of having to continue to fill out that paperwork even when those
doing it. And the people who work for those programs are also overworked and underpaid, and like paperwork delays and snafus happen because of that. So it's like
they try to make sure that no one really gets in here, like that you have to run not just a marathon, but like 10 across the world to be able to get to the finish line.
Right, and you have to carry like a full to the brim glass of water, and you can't spill any of it while you're running those marathons. Right, and it's like, let's just take the task and do something to make it like exponentially harder for no good reason. And it's another place where like culturally, like we would rather punish people than just like give them access to resources.
Right.
It's better for everyone if you choose that way.
Yeah.
Because like we all benefit from there being fewer unhealthy people around, you know?
Right. But it is always the most struggling parts. Like, and it costs so much more money. I think someone posted the statistics that when the exchange rate happens, that the UK spends £3,000 a year per person on healthcare, and the States spend $5,000 per pound, and somehow spend more, but still have worse statistical outcomes. And even like statistically breaking it down per capita, it's like still more, but we have less in the States.
Right. Right.
It's not a great deal. If I were buying it as like a coupon in the restaurant, I'd be like, it's not, no, 2 for 1, but I pay you 2 for nothing? Is that the deal?
Yeah.
This gets, he needs some medical care right now.
Well, his medicine is attention.
It's true. He needs some. So let's see. Next one is from Carlos. Would you choose George Clooney or Robinson Green to work with?
Neither. So I don't watch a lot of medical TV. I watched more when I was in nursing school, but now it's like being at work when I'm not at work.
Fair.
So I don't watch so much of it anymore. But if I had to work with a fictional doctor, I think it would be Miranda Bailey from Grey's Anatomy, because she gets the job done and she doesn't take any shit, but she's not mean about it, right? Like, and that for me, that is what I want from a provider, somebody who's just gonna answer the question without a bunch of bullshit in between, right? And they're not. And Miranda Bailey strikes me as a doctor who trusts nurses. And that is like working with a doctor who trusts you and trusts your judgment and like doesn't start from the assumption of like, oh, you're bothering me with some trivial thing.
Right.
Like it makes a huge difference.
Oh, I bet. I've read there's like a lot of beef between nurses with doctors, and
it's one of the things I like about working in emergency medicine is I think we have the least of that, because you can't screw around, and because like emergency nurses are often making a lot of judgment calls on our own. Like we have like sort of preset parameters of like, if this happens, you can do X, Y, and Z while you're in the process of getting in touch with the provider, or like getting, something like that to the bedside. Yeah.
Yeah.
And, it's also nice to like, I had a patient that had blood sugar of like it's 33 or something. That's not enough. It's like, that's a critical moment, you know, and I like, the treatment for it is just to give IV dextrose immediately, right? And that's a prescription medication. But when you have a high trust environment between, you know, your nurses and your doctors, I like was going to get the medicine. I walked by the doctor's station and I was like, hey, room 9, glucose of 33, I'm getting D10. Can you put the order in and meet me in there? You know, and like that just happens without a bunch of like delay and questioning. It's like, compared to, you know, I've never worked in any other context. It's always been emergency, and compared to what I saw like in nursing clinicals and that kind of stuff. And the other thing is, in emergency, the doctors are right there the whole night.
Right.
You don't have to page them. You don't have to like go through the intern and then the resident. You just go to whoever the most relevant. It's usually the resident for us, and like they know to respond to us quickly. And not like when we do. Sometimes we do have patients that get admitted and changed to an inpatient status while they're still physically in the ER. And one of the things that is frustrating about taking care of those patients is that, like, if you have a question for the doctor, you can't just, like, if they don't answer your message, because we use like a secure chat thing now. And so if they don't respond, you can't just go find them. And that, so being able to have that kind of close working relationship is one of the things I really liked about.
Yeah, the time pressure. Yeah, this takes out a lot of unnecessary layers.
And we are all, you know, we're all kind of working on top of each other. And so I get to overhear or participate in the doctor's process. And that makes me a better nurse because it's a teaching hospital. And so the attending physicians are working with the residents and they're teaching them as they're going through, you know, and so I get to hear a lot of that. And that means that I feel like a better educated nurse because I know what the conversation was behind the scenes.
Right.
So
I didn't think about that aspect. That's really, that would be fascinating.
Yeah. Well, and it's kind of like where I worked at my first job, it was even more like the workspace was even more shared than where I work now. And if we were having like a lull, you know, one of the attendings would just like pick a topic and give a little short lecture on it. And so there was like all kinds of like bonus education that you had access to.
I would love that.
Yeah. And because the attendings are all teachers, they're better prepared like to answer all of my annoying questions where I'm like, why is it like this? Like, this is sort of like a non-standard nursing question. It's not really part of the nursing education process or whatever. So, yeah. And we learn a lot from the EMTs too. Like, we, you know, talking to them and listening to their process and the kind of stuff that they have to deal with when they go out to somebody's residence or to an accident scene, and like how they handle it is all like, some of our nurses are actually both like, to me, it's insane. I don't know where they find the time and the energy to like work a full-time RN job, and then they also do like 1 or 2 EMS shifts a week. Like, that's
that being an EMT is like so much more active.
It's very different, but also they bring a really broad skill set to the bedside, and that's very ideal.
Yeah, if I was getting picked up by an ambulance, that would be the $10,000 worth. Right, not just like someone in training who doesn't know. I mean, it could be having an actual nurse. Okay, so here, this one is from Stephen. Would you consider, if the opportunity arose, moving to the UK to advance your nursing career? And if so, which field would you choose? And question 2, if I may, does nursing in the US feel appreciated by members of the public as much as it does for people in the UK?
So I'll answer the second part first because that's a little more straightforward, which is, I think, yes. Like, nurses have I think it's like firefighters and nurses are like the 2 most trusted professionals in the United States. And I take that pretty seriously. It's part of why I wanted to go to nursing school, and also like it matters to me a lot that like if people have questions, I like answer them carefully, like answer them accurately, and I'm very much like, if I don't know something, I will find out if I can. And sometimes, if I'm in a patient's room doing something and they ask a question and I don't know, I'm like, well, let's just go to the database. Let's just look it up together. And then we kind of go through that process together. And I think that like being transparent about that kind of thing also builds trust.
Right.
So yeah, and I think nurses are definitely appreciated. I think that there is a little bit of that like, well, you get paid in appreciation rather than money kind of attitude, which I think has gotten better since COVID.
Yeah.
I changed before and after the start of the pandemic, like I changed my work context pretty significantly and had a, concurrent change in how much I was being paid. But there's so many things there. Like, I don't know if it was actually like an overall improvement in nurse pay, but yeah, there's certainly a lot of appreciation, but sometimes you feel like there's only so much appreciating you can do. Like for example, everywhere I've ever worked where they celebrate like Nurses Week or whatever, like I would get on my little soapbox about this like every year. My coworkers got tired of it. I'm like, I don't need another water bottle or cooler or bag with my hospital's name on it. Like, I'm also like, you're appreciating me in the form of like, now I'm advertising for you. Right. And it's also like, it's a jump, right? Okay. They give me a $25 gas card. It's so much better for me.
Extra vacation day.
An extra vacation day.
Something actually useful, yeah.
Yes, or like the hospital where I work now does do like free meals during Nurses Week, like real cafeteria meals.
Yeah.
But like the hospital where I used to work did not. And that was just like, geez, hold on.
Right.
I kind of feel like your hospital has a cafeteria and you work there, you should get to eat for like a hefty discount.
Right.
The first hospital I worked at, like you got no discount on your meal whatsoever if you bought food from a cafeteria full price.
That is nuts.
Yeah.
Especially considering how many like tech companies have just free breakfast, lunch, and dinner, but
Yeah.
your job is saving people's lives. They're like, no, we can't like give you fuel for your body for free. Like, that's your public.
Yeah, and like yes for a lunch break. That's my biggest complaint with my current job is that like I think if there were a like if the nurses of the department like really pushed about it and did some practical things to make it happen, like did the like coworker organization to like make it happen that like we could arrange for people to have actual lunch breaks. But I think I've had like one real lunch break since I started my current job.
Do you not get like specific time off?
We're supposed to.
Yeah, I thought
We're supposed to.
but it's like just because the work situation is kind of the excuse for like this is an emergency, we can't afford to have anyone take a lunch break.
Yeah.
Jeez. Well, even I'm learning something new about the American healthcare system all the time.
If you liked this video, please do me a favor and give it a like and subscribe. Also, special thanks to my members and our weekly live stream every Sunday night. I've also set up a store now if you want to check that out, as well as a Patreon where you can get access to videos not on my channel, as well as early access without ads to videos from this channel. Thanks. I'll see you in the next one.